Hello, everybody, and welcome to today's webinar, The Basics of Memory Loss, Dementia, and Alzheimer's Disease. My name is Lucy Gerland. I'm a caregiver specialist with the Fairfax Area Agency on Aging. During today's webinar, you will be in listen-only mode, and you can type your questions in your panel on the right-hand side. There's a space for questions. And I will ask the speaker your questions at the end of our presentation, which should be around 12:45 p.m., and we'll wrap up the webinar by 1 p.m. Our speaker today is Diane Vance, Programs and Services Manager from the Alzheimer's Association National Capital Area Chapter. Diane has worked for many years in Alzheimer's and dementia care, both professionally and as a family caregiver. She provides community education programs, professional caregiver training, support and memory care facilitator training, and care consultations for the Alzheimer's Association. Prior to coming to the association, Diane worked as both the Director of Dementia Care Services for an assisted living community and as Director of an adult medical day program for elderly individuals with cognitive impairments. She is a passionate advocate for individuals and families affected by Alzheimer's and other dementias and enjoys providing training and support at all stages of dementia care. So Diane has a lot to share with us, and I'm very excited to turn the webinar over to Diane Vance.
Thank you. So today we're going to go over the basics to get a general overview of what is going on with this illness and other dementing illnesses. So let's get started. You'll hear from me, and you'll also hear from others who, you're going to also hear from some others who are in this video, both caregivers and professionals. So we'll start now. And this is Dr. Peterson.
In general, we talk about individuals age 60. People have perhaps an 8 to 10% risk of developing Alzheimer's disease over their lifetime, but it's clearly age-related. So if your family tends to live into their 80s and maybe 90s, your risk is going to go up rather.
Excuse me, Diane, I'm having a hard time hearing that.
In the 70s, the risk is lower, but it's clearly an age-related phenomenon. And with baby boomers, now those individuals born between the years of 1946 and 1964 moving into their 60s.
Yes, I'm getting messages that other people can't hear it.
Yeah. Okay. Well, it's up as loud as it goes, so I'm not sure what I should do.
Okay, well, we may need to skip that, and you can kind of summarize what he was talking about.
Yeah, let's do that. Okay, so I understand people can't hear that. I don't know what the problem is, but he is just really talking about how Alzheimer's disease is an age-related illness, and that the older we get, the higher our risk of developing this illness is. There are younger onset types of Alzheimer's disease, but those are really a fraction of the, I think right now we're at 5.5 million people with this illness, so it's a very small number that has the early onset type. So what is age-related memory loss? You know, we all have typical aging, right? So we all have we all forget things once in a while or make a bad decision. We might miss a payment on something that for a few days. But we usually remember things later. And we might have some word finding issues because as we age, our brains shrink a little bit, as does the rest of us. And so some things become harder to do, like right now, I'm having a hard time finding a word. So we might lose things from time to time, but the difference is in typical aging, we are generally able to retrace our steps, go back to where we started from, and find what it is we're looking for. And usually we don't put things in really odd places. We might put our keys somewhere different than we usually have them and then not find them, but we're not usually putting them in the freezer or the washing machine. This is Joyce, and she has Alzheimer's disease, and what she's going to talk about, and I'm going to skip it, But what she has to say is that she first noticed that she was having word-finding difficulties, and this is very typical for Alzheimer's disease, that the first sign is often memory, word-finding trouble. But Joyce then realized also, she was still working, she has a PhD, that she was unable to send coherent emails any longer, and she was forgetting how to spell not big words, but small words like the and of. And finally, her sister wrote to her and said, you know, your emails don't make any sense anymore. You need to, I don't know what's happening to you. And so that's how she ended up going to a doctor and getting a diagnosis. So what we talk about when we talk about Alzheimer's and other dementias is that people start to have problematic changes, right? So these are memory changes that disrupt the daily life of the individual. Because the executive functioning of the brain begins to be affected, there are major challenges in planning or solving problems and difficulty completing familiar tasks. So you might hear people say, well, you know, I noticed that my mother could no longer balance her checkbook, and she was always very fastidious about that. That's because the part of the brain that is able to complete that task is now being affected by the illness. People can get confused with time and place and not be able to recall. Most of us, as retired people, often have confusion with time, but they're usually able to look at a calendar or a newspaper and figure out, you know, where they are. People begin to have trouble with visual images and spatial relationships, and this is because people develop, along with the normal visual challenges that come with aging, cataracts, glaucoma, things like that, people with Alzheimer's disease often develop a loss of peripheral vision, and they have a lot of trouble discerning color contrast, and their spatial vision is flat, so they no longer see in 3 dimensions. So you can imagine if you can't see depth and you come to a stairway, you're going to have a lot of problems, and it becomes really dangerous. And this is, you know, a lot of times we'll see people with these illnesses start walking very gingerly, like they're very afraid of falling, and they are, because a lot of this has to do with their inability to see very well. They develop new problems with words and speaking or writing. They misplace things, as I said, and can no longer retrace their steps to find the thing that they lost. And they have decreased or poor judgment. And so they are very vulnerable to exploitation of very many kinds, but especially financial. There's a lot of phone scams that prey on elderly people, and so those who have decreased judgment are at higher risk. They withdraw from social activities or their work, and this is the worst thing that anyone can do, because research has shown us that continuing your social activities, continuing your social circle, and being with people who care about you and love you is actually protective for the brain. So, you know, when people isolate themselves, they usually get sicker faster. And then sometimes we see changes in mood and personality. So what is dementia? Because people are always asking me, well, what's the difference between Alzheimer's and dementia? So dementia is an overarching definition. And under that definition, there's Alzheimer's dementia, vascular dementia, frontotemporal dementia, dementia with Lewy bodies, and what we are now calling mixed dementia, which is more than likely in elderly people, Alzheimer's disease plus a vascular dementia of some kind. There are many other kinds of dementia. There's a Parkinsonian dementia. There's a dementia that happens, an alcohol-related dementia. So, but these are the types that we see most often. And Alzheimer's disease is the most prevalent type of dementia that we see. So about 50 to 70% of the dementia that we see is the Alzheimer's type. And then a large portion is the Alzheimer's type plus vascular dementia, because there's so much vascular illness in people who are elderly. So this is Steve, and he has a diagnosis of Alzheimer's disease. He has a younger onset diagnosis, and His symptoms came on very dramatically, and so he was at work one day, and he said he sat at his desk and he had no idea what he should do next. And so he ended up sitting at his desk for about 3 hours trying to figure out what is the next step for him. And of course, he then went to a doctor and got his diagnosis of Alzheimer's disease. So dementia is a loss of cognitive functioning that's serious enough to interfere with the daily functioning of an individual. So forgetting minor things is not going to interrupt your life very much. But when these changes start interfering with your life, it's time to really get checked out and make sure that you're ruling out other things that it could be. And that is the first stage in a diagnosis, is that a doctor will rule out everything else it could possibly be. But we begin to see changes in memory, language, thought processing, navigation, behavior, mood, and planning and organizing. But there are many, many illnesses that mimic dementia. And so I always tell people, you need to go to the doctor because you may not have dementia at all. And that's what people are afraid of, and they don't go to the doctor. But there are many disorders that mimic dementia. For instance, there's hypothyroidism or other metabolic disorders, a brain tumor. Dehydration in elderly people can make them seem extremely demented. Emotional disorders, sensory loss that people experience because of other illnesses, vitamin deficiencies, especially B12 deficiency, infections, and we see this often with people who have urinary tract infections, and then any kind of alcohol, drug, or medication interaction. So all of these things can mimic Alzheimer's disease or another kind of dementia. And if you go and you get treated, you're fine afterwards and you no longer have these symptoms. If you don't get treated, some of these can be very, very serious. And if you have an untreated infection in an elderly person, they're likely to get septic and they might not survive that. So it's very important when you see these symptoms to not put off going to a doctor because the sooner you get treated for anything, including Alzheimer's disease or other dementia treatments, the better off you're going to be. So usually the first thing that happens is someone gets diagnosed with what we call mild cognitive impairment, or MCI. And this is likely the first thing that a doctor will tell you. So this is impairment that's severe enough to show up on a test, and these tests are very comprehensive. So it's not like a little mini mental exam that you might get in a GP's office, but it's a series of tests that are done to really test you in all kinds of areas, your motor control, your comprehension, your memory, all of these things. So, but this is not an impairment that's severe enough to affect your daily life. And although it increases your risk of Alzheimer's disease, it does not mean you're going to have Alzheimer's disease. So many people with mild cognitive impairment stop at that point and they don't go any further in the illness, and they still do everything that they normally did, including driving. They're pretty much fine. Vascular dementia is caused by damage to the vascular system. So when people have heart attacks or strokes, or we have these what we call TIAs, these little mini strokes that often people don't even know that they've had, they're so minor. But when you have enough of them, you impair the blood flow to the brain, and this causes dementia. And it frequently exists alongside of Alzheimer's disease, and it is seldom the lone cause of dementia. So if someone, it's very infrequent that someone has only vascular dementia. They usually have both dementias at the same time. A mixed dementia is Alzheimer's disease and another type of dementia. And that's most commonly, as I said, Alzheimer's and vascular dementia. It may account for nearly half of the causes where Alzheimer's is present. So as I said, with elderly people, the chances go up that you have some sort of vascular problem, hypertension, whatever, that is also present along with the diagnosis of Alzheimer's disease. So dementia with Lewy bodies is a special category, and it has Lewy bodies are a protein that we have in our brain, and when those proliferate too much, we get this dementia with Lewy bodies, which some of the hallmarks of that are hallucinations, tremors, and a kind of rigidity that's similar to Parkinson's disease, where people have a hard time getting started moving. Their hallucinations are sometimes frightening, but they're often very benign. And I worked with a guy who had this type of dementia, and he saw these little people all the time, about 2 inches tall, and he was very concerned about them all the time, but they entertained him endlessly. So, you know, it's not always a bad hallucination, but they do have a lot of hallucination. Frontotemporal lobar degeneration, what we call frontotemporal dementia, is when the front of the brain is injured too many times. And we see this a lot in sports figures, for instance, who develop dementia after having many concussions. It can begin at a much younger age than Alzheimer's normally does, typically 45 plus. It progresses much more quickly than Alzheimer's disease. And the symptoms are usually changes in personality, concentration, social skills, motivation, and reasoning. And this is a very frightening kind of illness in that because it's in the frontal lobe of the brain, that's where our police reside, right? That's where we have our impulse control. And this is the reason we say kids shouldn't be making any important decisions until after they're 22, because it's the last part of the brain to develop. So people who have this kind of dementia can become very disinhibited and exhibit behaviors that they normally would never exhibit, and some of them are very embarrassing to families and friends. So this includes dementias like behavioral variant, FTLD, primary progressive aphasia, which is all about inability to use language, Pick's disease, corticobasal degeneration, and progressive supranuclear palsy. So these are all big words for the types of deficits that people who have frontotemporal degeneration might have. Other rare brain disorders are Creutzfeldt-Jakob's disease, which we used to call mad cow disease, Parkinson's disease, Huntington's disease, which used to be called Huntington's chorea, normal pressure hydrocephalus, Wernicke-Korsakoff syndrome, visual processing disorders related to dementia, cortical atrophy, and cortical visual impairment, and that's because the occipital part of the brain is damaged. Let's talk about Alzheimer's dementia. And we no longer use Alzheimer's disease as the word for Alzheimer's dementia. And this is because we've now learned that there's a long arc to Alzheimer's disease. So you can have a disease for a long time before you're symptomatic. So we call now the symptomatic phase of this illness Alzheimer's dementia. But you can have a disease for a long time before you show any signs of the dementia. This is Laura, and her husband has a diagnosis of Alzheimer's disease, and she just talks about how there are so many misconceptions about what a person can and cannot do with this illness. And often we think of people with Alzheimer's disease in the last stages of the illness. That's our image of Alzheimer's disease. There are so many people with this illness who are out and about in their communities. They're working hard. They're advocates for the cause. They, you know, they're going about their lives as normal. And they're trying to plan for their future. So Alzheimer's disease is a brain disorder, and it's progressive, which means that it continues to deteriorate over a long period of time. It is the most common form of dementia. It has no cure. It is a fatal illness, and the number now is 5.5 million Americans have this illness, with about one person acquiring the illness every 66 seconds in this country. So it's a very big problem. It's an epidemic, really, that people are not really paying quite enough attention to. So we have 100 billion nerve cells, or neurons, in our brains. And you can see from this illustration that they have these branches that connect to one another, and they speak to one another. So these signals travel and form everything that we do, our memories, our thoughts, our feelings, this is the command center of the brain. And Alzheimer's disease destroys these neurons. So when the neurons are damaged, they die off, and they leave a plaque on the brain that we call amyloid plaque. And then these fibers that you see, these branches that you see, they actually have a fiber wrapped around them. And so when the neuron dies, these fibers unravel, and they leave what we call tangles on the brain. So we talk a lot about plaques and tangles with Alzheimer's disease as the cause of the damage to the brain. And here's a picture of them. So you can see sort of what we think these plaques and tangles look like on the brain. And now you can actually see this in the brain with brain imaging that they can do now. So here's your brain, and it's an amazing, amazing, amazing thing. And so as you can see, different parts of the brain have very different jobs to do. So if you're looking at what we call the reptilian brain, this part right down by the brain stem, that handles all of our automatic stuff, breathing, heartbeat, everything that we do without even knowing that we're doing it, right? The occipital lobe is in the back where vision is, judgment and reasoning is in the front where the frontal lobe is, and then other things are in other places, right? So for instance, what's affected in a person depends on what part of the brain is being affected. So language, for instance, happens in two parts of the brain. So the part of our brain that speaks is separate from the part of our brain that understands language. And as a result, someone with Alzheimer's disease may be able to understand everything that you say, but may not be able to speak to you.
I got here right before it started because I had a little sick leave.
Okay, so and the part of the brain that speaks, someone can talk to you very coherently, but they might not be able to understand a thing that you're saying to them. So a healthy brain is very tight, very compact with a lot of white matter, and it fills the skull, and it is also protected by the fact that it fills the skull, right? So it's not moving around up in there and getting banged up. And this is why a concussion is so bad for you, or why a whiplash can shake your brain, any really hard movement. With Alzheimer's disease, the ventricles enlarge, and you can see them as those black places inside the brain there. And the cortex shrivels, especially near the hippocampus, which is the area of the brain that is where our memory resides. So who's at risk? The primary risk factor for Alzheimer's disease is definitely age. And the incidence is higher in women than men. We have said because women live longer, but there may be other mitigating circumstances that we don't completely understand yet. Down syndrome is also correlated with Alzheimer's disease. People who have Down syndrome as they age develop Alzheimer's disease, and this is because of their increased lifespan. Family history can increase your risk, but it doesn't doom you to acquiring this illness. And there are two categories of genes that we see in people who have Alzheimer's disease. Also, African Americans are twice as likely to have Alzheimer's disease as Caucasian Americans, and Hispanics are 1.5 times as likely. So these groups, I think because of their historically not having access to good health care, good nutrition, plays a big part in why they might have a higher risk for Alzheimer's disease. So a lot of people will ask, if I have a head injury, am I at greater risk for Alzheimer's disease? And the answer to that is it depends on the head injury and how severe and how many head injuries you've had. But yes, it can increase your risk. Does my diabetes and my high blood pressure put me at higher risk? And the answer to that is yes, it does. Because these are things that can damage the nervous system in the brain. Can doing crossword puzzles reduce my risk? Everybody wants that to happen. I will tell you that my mom has Alzheimer's disease, and we take care of her at home, and she's always done crossword puzzles. She can no longer do them, but she sits and tries to do them still day in and day out. So why didn't this protect her brain? Maybe it did for a while, but really the thing that's going to be better for your brain are new things that you haven't done your whole life, right? So challenging your brain reduces your risk. So if you've always done crossword puzzles, that's not going to be very challenging to your brain because you know how to do it. But maybe learning an instrument would be, or learning a language would be. Can broccoli be a preventative tool? Good nutrition definitely protects the brain. So the thing of it is that, you know, what we can do about Alzheimer's disease at this point in time has everything to do with how we take care of the entire organism, which is our body, right? Our mind and our body are connected, so the better care we take of our heart, our body, our vascular system, you know, keeping good social connections, all of these things are beneficial and protective of the brain. And even people who get Alzheimer's disease may have a longer period of where they're asymptomatic, where they don't show signs of it because of taking these steps to protect themselves. So how do we get through a diagnosis? This is often so scary for people. But doctors can now diagnose Alzheimer's disease with greater accuracy. And so normally people would start with their primary care physician and from there be sent on to a geriatrician or a neurologist, psychiatrist, or neuropsychologist, but mostly these days people are either seeing a geriatrician who specializes in Alzheimer's disease or a neurologist who specializes. And these are the folks who can most accurately diagnose you. A primary care physician may not be skilled at diagnosing this disease, and a lot of times we find that primary care physicians will just tell older people, you know, this is just all part of getting older. And so a lot of people go undiagnosed who have this illness. You want to keep a log, whether it's for yourself or a loved one. So you want to write down your symptoms and be very specific, include when these symptoms happen, how often and where. If you have a hard time remembering, you might want to ask your family or friends to help you make this list. And this is true for any doctor's visits. Doctors have about 10 minutes to spend with us when we see them, so we have to be very prepared with our questions. Always bring a list of current and previous health problems, and doctors always want you to bring all of your medications. And medications are a problem because pharmacy is not well understood in the elderly. So, you know, we get prescribed things for hypertension or heart disease, whatever it is. You know, we might get those in middle age, and we get to be 80 and we're still taking the same medication at the same dose. Well, our bodies are metabolizing those chemicals in a very different way by the time we're 80. And, you know, the most, I always say when I was 21, I could drink, you know, several glasses of wine and be fine, and now I drink a glass of wine and I have to go to bed. I'm too tired. So that's because my liver is metabolizing things in a different way now. The doctor will always want your family history. They will do a thorough physical and neurological exam, which will include lab tests to rule out every other possibility, mental status exam. They might want to do some brain imaging, and they might want to include some neuropsych tests to see how you're doing. Usually people take a lot of tests before they get a diagnosis. So what happens when the diagnosis is Alzheimer's disease? People have a lot of different feelings when it is Alzheimer's disease, of course. A lot of people are in denial and refuse to go to the doctor or refuse to accept what's happened. And then some people feel very relieved because they don't feel like they're crazy anymore, right? They have been very aware that something is wrong with them. And so sometimes finding out what it is relieving, even though it's very difficult disease for the person who has it and the family. It's a family illness, so everybody shares in the difficulty. We talk about 3 different stages of Alzheimer's disease for the most part, which is the early stage or the mild Alzheimer's, which is memory loss that's recent, and difficulty driving or handling social situations or managing money. These are mild, and people still are very active and able to get along very well independently in the early stage. The middle stage, moderate Alzheimer's, people begin to have more and more difficulty with language, finding problems, and problems keeping track of their belongings, and they may start to pay far less attention to their, whether their clothes are clean or dirty, or whether they themselves are clean or dirty. And then the late stage is severe Alzheimer's. Both the long and short-term memory are affected, and people begin to need care around the clock. Now, keep in mind that all these stages are very malleable, and everything depends upon what area of the brain is being affected. So we might see things in the early stage that we normally see in the middle stage. So it's all of these are just basic concepts around what we expect to see at the different stages. This is Dr. Parker, and she is a geriatrician at Emory University, and what she says is that people do not plan early enough for what they want to have happen if they get a diagnosis of Alzheimer's disease. And so she's saying, talk to your loved ones now. If you are talking about your parents, talk to them while they're still able to tell you what their wishes are, what things they need to get in order, etc. And if it's yourself, it's never too soon to begin to let your family members and loved ones know what your wishes are. And you can simply write down these wishes and sign them, and a doctor is probably most likely going to respect them. If you have a large estate, you probably want to see a lawyer, an elder who specializes in elder care, to make sure that what you want to have happen with your finances does happen. So we always say plan early so you can be an active partner in your long-term care plan. People often say to me, well, why should I want to know that I have this disease? Because there's no treatment for this disease. And so it's a fatal illness that I have. I'm going to lose all of my memory, and then I'm going to die. Why would I want to know this? And the reason you want to know it is because all of the medications for this illness that manage symptoms, we don't have any medications yet that manage the disease, but we do have medications that manage the symptoms, and those are most effective the earlier you take them. They also will last longer the earlier you take them. Now, they don't work for everyone, and they don't work all of the time, but they do manage symptoms for a lot of people, and that's a plus. You want to be an active partner in your long-term care plan. So you want to put your team together, right? When you're still able to say to your daughter, I don't want you to kill yourself taking care of me, or say to your children, I don't want to be, what you would like to have happen to you. Like, I don't want a feeding tube. I want to go on hospice care at that point. Whatever your desires are, I always say, if you don't tell people, someone else will be deciding for you what's going to happen to you. It allows you to develop a relationship with your healthcare team, and the better your relationship with your team, the better off you're going to be. It allows you to get your legal and financial issues in order. It helps you to be able to grow a support system who can help you stay as independent as you can possibly be for as long as you can be. And what we see with this illness and what research has taught us is that people who have strong support systems are able to stay independent much longer than those who do not. And also it allows you to educate yourself about the illness so that you can figure out what it is you want to have happen to you. So the medications that we use to treat symptoms, and again, these do not alter the trajectory of the illness, they only treat symptoms, and these are the cholinesterase inhibitors like Aricept And Exelon, I don't think we see Razidine as much anymore, but definitely we still use Aricept, Exelon a lot. And then the MMDA receptor antagonists, or what we call Namenda is the brand name, that we see most often, which helps with symptoms. So as I said, these medications only work for a short period of time and only work for some people. But the earlier you take them, the longer they are effective, or even the likelihood that they will be effective is higher. This is Dr. Peterson again, and he is telling you what I just told you about medications, that the efficacy of them are modest, but in some people they work quite well. You can get into a clinical trial or clinical research if that's what you want to do, and these fuel our progress towards treatments. And participants in these clinical trials receive a very high standard of care. So often they're looking for people with Alzheimer's disease or other dementias, but they also look for people who have this in their family but are not symptomatic yet or at all. And there was recently on 60 Minutes a program about a family in Colombia where they have the familial type of Alzheimer's disease, the very rare type that everyone in the family gets the illness. And they're studying the well people because the push now with research is to try to find these biomarkers that tell us that someone has this illness before they're symptomatic, because once the damage happens to the brain, we can't really undo it. We can't undo brain damage, and this is what we've seen with some of these clinical trials that have failed. But if we could find the markers that show us that somebody has it and we could get them into treatment before they have symptoms of the illness, we may find a way to slow it down and eventually find a cure, which is, everyone's hope. The Alzheimer's Association provides tons of resources to help people, and we do so at no cost, and we partner with the AAAs and other area agencies to make sure that people are getting the help that they need. So at our website, we have a navigator, a community resource finder where you can just put your zip code in and say that you're looking for home health care or a neurologist or whatever it is you're looking for, and it will populate a list with people in your neighborhood. We have a caregiver center that has lots of tools. We have a safety center for safe return bracelets and things like that. We have a helpline that's available 24 hours a day, 7 days a week, every holiday. You can always talk to somebody there, and there are always social workers there who can talk to you and help you navigate the problems that you're having. And even in the middle of the night, if that's the only time you can call because you're taking care of someone with Alzheimer's disease, they're going to be there for you. We also, of course, have a number of support groups throughout the region. We do education programs like this throughout the region and really all over the country. And we have education programs available as well. So we are happy to help. We do care consultations for people who are sort of overwhelmed. We don't do, we're not like a geriatric care manager, but maybe before you contract with someone who is a care manager, you might want to come in and talk to us and see if we can help you sort of navigate where you are and what your next steps might be. As I said, we don't charge for any of our services. And we also would love you, of course, to get involved with our Walk to End Alzheimer's, which happens in the fall in a number of communities throughout our region. The longest day is our events that happen in June, especially on the 21st, which is the longest day. And then our trial match programs, we do have on our website a way for you to put your information in there and get matched so that you don't have to like research all of the research that's being done. We'll actually match you with research that looks like it matches what your needs are. And we have advocates. And so if you're interested in advocating with Congress or your representatives, we have a whole department that does nothing but advocate for more money for Alzheimer's research and care needs. This is a disease that is breaking the bank. This is Betsy, and her husband had Alzheimer's disease, and she was part of a support group. And she just talks about how important that was to her, how much she learned from it, how it helped her understand that she wasn't alone. So she recommends it. And so to learn more, please go to our website. We're happy to help you with anything there, or call our 800 number. Let's go back to that. Where did I find that? There it is, 800-272-3900, and you can get help there. And finally, we have a very robust website, and our local chapter website is alz.org/NCA for National Capital Area. And you can get in there and look at our calendar, and you will see all kinds of things that are happening around the region that you might be interested in learning more about. So thank you so much for attention that you've paid to me today. I'm sorry about the video parts, but I think I gave you pretty much the gist of it. So I can answer any questions that you might have at this point. I'd be happy to. I think we came in a little bit under our 45 minutes, so good for us.
Thank you, Diane. Yes, and I do have some questions for you.
Okay.
I also personally want to ask you about something. My observation with my loved one is that her brain seems to warm up as we're going along. So if we're playing a game or, spelling words, at the beginning, she has a really hard time coming up with words and spelling. And then as we progress, it's going faster. Is that?
Absolutely.
Yeah.
Yeah, I think that we find this a lot. With severe Alzheimer's disease, for instance, for people who are in congregate settings like memory care units, we will see that people who seem not able to brush their teeth, if we do a little what's called hand over hand with them and get them started, we can let go and they'll finish brushing their teeth. It's like exactly what you're saying, a kind of warm up. The same with eating. If we help them locate their utensils, help them remember what it's for, then they're able to independently do it. Alzheimer's disease is a very interesting disease in the way that people have very good days and very bad days. So I might if I have this illness, I might wake up one morning and totally get myself dressed and ready to go and come into the kitchen and say, where's my coffee? It's a good day. The next day, I may not have the foggiest idea how to put on my clothes. And with families a lot, we see this frustration of, a caregiver being very frustrated that somebody's purposefully trying to frustrate them by pretending not to be able to do something. But the fact of the matter is they really cannot do it. And so a lot of times we see this. So somebody's having a good day, they might be very sharp. And if they're having a not so good day, they will be very dull. And a lot of the time, if we spend enough time and we're patient enough, we can really get that person to do all kinds of things, like you're talking about with word finding games and things like that. And that's partly because what happens in this illness is the processing time for anything gets very slow. So you can say hello to somebody and they might appear not to understand anything that you say, and 3 minutes later they'll say hello back to you. So this is the importance of being able to keep still, which is very hard for us because we're a very fast-paced culture, and wait for somebody. And from the mid to end stage of Alzheimer's disease, it's believed that people only understand about every 3 or 4 words that we're saying to them. So understanding what's being said can take a very long time, and people are working really hard to try to figure out what we're asking of them, because of course they want to be compliant, they want to be involved with us. So patience is one of the greatest gifts that you can give somebody.
Oh, thank you very much. I would hope that that information would be provided in professional caregiver trainings as well as to family caregivers, but I find sometimes with a professional caregiver that if a person is unable to do something one day, then they just, okay, well, she can no longer do that, so I have to
But
help her.
yeah, it's funny that you say that, because I think it really depends, and this is a question you want to ask when you're looking at places where you might want to place your loved one. What kind of training do they get? Yesterday I did a 7-hour training at a assisted living community that covered all of this plus much more. And the two pieces of feedback that I always get when I do these trainings, our professional trainings in those places, long-term care or assisted livings, is one, you need to give this training to our administrators, and two, I'm learning a lot of things that I never knew, because you don't get this training. When you go to CNA school, you don't get trained to be an Alzheimer's caregiver, and it's not for everyone. It really is not. It takes a special talent to work with people who have these illnesses. And just to drive home the point, what we see when you start, like, let's say somebody isn't feeding themselves. You know, that could be because the plate is in the wrong place and they don't even see it. It could be because there's not enough contrast between the food and the plate that the person can recognize that there's food on the plate. It could be because there's too much food and the person can't make a decision about what to eat. It could be because they've forgotten what their fork and knife are for. So, you know, if it's the case that they've forgotten, you can jumpstart that. You can put them at a table. A lot of times people who seem not to be able to eat get segregated into the quote-unquote feeder table. But if you mix people together with different skill levels, they will be looking at each other, right? So they'll figure it out. But yeah, I think it is a big problem in assisted living because of the staffing difficulties. They're always operating with not enough staff. So people don't have, and they are demanding so much of their direct care workers. So I know where I was talking yesterday, they said that they have a 7 or 8 to 1 ratio in their dementia care, which is horrible. So I would always ask, how many direct care workers do you have? And that's because they will tell you, oh, we have a 6 to 1 ratio, which is probably fairly good, not in my view, but in terms of what's available out there. But they're including a nurse who's not on the floor, an activities director who's not on the floor, and the director of the unit who's probably also not on the floor. So that's 3 people in that 6 to 1 ratio, right, who are not on the floor all the time. So you want to ask them, who does that ratio include? You just have to be a savvy consumer.
I think that's all very good information, and for us as family caregivers, whether the loved one is in a facility or at home, to know, you know, these things, if we have a caregiver coming in, to just make sure to continue to let them know and help them understand that there are changes from day to day, from, you know, from morning to evening, and even from just the beginning of a meal to the end of a meal, so we can help our caregivers help our loved ones, and even for ourselves to know that as family caregivers, I think is great. So thank you. I have more questions coming in, and I'll just remind people that you can type in your question in the questions panel. The next question is, what is the current thinking on coconut oil and B12 for helping?
Okay, coconut oil, we're not seeing any evidence in the research, and the Alzheimer's Association goes strictly by the research. So something that's being offered but has not been really tested thoroughly, we can't recommend or not recommend. I mean, in terms of coconut oil, I don't think it's going to hurt you, but I haven't seen any evidence that it's going to cure your Alzheimer's disease. What was the other one?
B12.
B12. I would not increase B12 unless my doctor told me to, because you can take too much B12 and that can affect your blood. So, you know, with anything like that, I would always be asking my doctor, because they can do blood tests that look at your B12 levels and tell you whether you need more or not.
Okay, thank you. How do medications affect symptoms of Alzheimer's? How does it help?
So some of these medications that we give people help with their memory in the short term. They don't help in the long term, but they do help in the short term with memory for the people for whom they work, and this is the important part. And the other thing is that they can have a positive effect on mood. So, and then the third thing that we've seen is that, you know, often people who have diagnosis of Alzheimer's are depressed, and they do well on an antidepressant, which I didn't mention earlier, but that's another thing to speak to your doctor about. And there have been some research preliminarily that's showing us that like Zoloft and Aricept together seem to work a little bit better than either one alone. So again, you know, you want to make sure that you have a doctor who you trust and who is knowledgeable about this illness and up to date about this illness, because there's new information coming out all the time. And like I always say, some doctors graduate at the top of their class and some doctors don't. And we don't get to know which is which. So you really want to vet your doctors carefully.
Thank you. Does it make a difference in treatment if it's Alzheimer's or some other type of dementia?
It depends on what other type it is. So if you have Alzheimer's and vascular dementia, your treatment is probably going to be pretty much very similar. If you have a Parkinson's dementia, then your treatment is going to, of course, be affected by your Parkinson's disease. So, you know, there's really not very much treatment for this illness right now. So, you know, in all honesty, in my view, the treatment for Alzheimer's disease is loving care. I mean, that's the best thing that we can do for people. Patients, loving care, support, help them allay their fears, and be very supportive. It's all on the emotional level. And, you know, it makes total sense. People with this illness are very afraid, and I would be too. So, you know, anything that you can do to sort of support them in terms of their fears and their independence, you want to do. So the treatments that we're seeing right now, really, I mean, if you have vascular dementia, of course, your doctor's going to want you to stay on your blood pressure medication or your heart medication, whatever it might be that you're taking. But as for treatment, there's very little treatment at this time.
So, for instance, if a CAT scan was recommended by a physician, is it more just for their curiosity, or is it going to help them do anything?
It might help, because if they're asking for brain imaging, what they're trying to figure out what type of dementia are they seeing. So, and so that matters in the sense of, you know, if they're seeing dementia because you have a brain tumor, they might be able to take that brain tumor out and you'd be fine. So you want to look for that kind of stuff. But also just in terms of identifying the illness, because we're trying to keep good records. They're trying to look for people who can go into clinical trials. I mean, there's all sorts of things that you might want to do once you have a specific diagnosis. And so there might be one group of researchers that's strictly working on Alzheimer's disease, and there might be one that's strictly working on vascular dementia. And so, you know, even though what we see exhibited from a person is very, very similar, the research on the brain may be very different. Of course, I'm not a researcher, so I'm limited in what I can tell you about that.
Thank you. And what makes Alzheimer's a fatal disease?
Alzheimer's is fatal because if something else doesn't kill you along the way, eventually your brain will be destroyed to the point that that reptilian brain that we talked about earlier is affected. And so once you forget how to breathe or how to keep your heart beating, you die. And that's really how people with Alzheimer's who have nothing else going on with them health-wise, that is how it happens. Although that's pretty rare in my experience, because usually people have, by the time they're 80 or 85 or 90, you know, they have a lot of mitigating illnesses. So something else usually happens.
Thank you.
Mm-hmm.
Should I be enforcing the truth with my loved one, for instance, reminding them when they ask about a person who died, reminding them that that person is dead if they say, I want to see my mother?
Okay. This is a hard one for people because we want to always, you know, our instinct is to reorient people. But if someone really can't remember, they can't remember. And so normally if someone's asking for their mother, I would try to distract the conversation in some way so that I'm not actually lying to them, but I'm sort of reorienting them, like in terms of a conversation, for instance, by saying, what do you love most about your mom? And then from there talk about, well, when you were little, what was your mom like? And then go on to, oh, well, when you were little, did you have any pets? And sort of just move the conversation away from mom. If it's really impossible to do that, I will often wait for someone, for instance, with my own mother, she will ask about friends of hers who have passed away, and she will ask, and then I don't say anything. I'm just sitting with her, and I give her a little bit of time, and she'll go, they died, didn't they? And I'll say yes, and she'll say something like, I can't believe I don't remember that. So a lot of people recommend therapeutic fibs. I always think there's a little bit of danger in that because you can get caught in them, and then that's a whole nother problem that you're going to have with trust and other things. But I am a firm believer in distracting conversations to get people sort of off the subject. And I'll tell you a little story. When I was working in the day program I had a woman who would come in, and every day she came in for her mom, and her mother would say, where's your father? And she'd say, Mom, don't you remember Dad's dead? And the woman would start crying, and then the daughter would start crying. And after about 3 days of this, I was new, I asked the daughter to talk to me, and I said, why are you answering your mother this way every day? Because clearly it's traumatizing for both of you. And, you know, maybe you could just say he's not here right now, or he's at work, and avoid this kind of trauma every day. And what she said to me was, well, I've never lied to my mother. And it was very hard for her to do so. But reorienting her mother was not helpful. So.
Right. And, you know, perhaps at different stages too, you know, as a person progresses and they don't remember from 5 minutes ago what you tell them, to continuously tell them, you know, so-and-so is dead is not really helpful.
No, I don't think so. I think it's hard for the family member, and it's hard for the person, because you have to remember they're experiencing that loss as if it's the first time.
Right. Mm-hmm.
So why, you know, when you think about it that way, no one wants to tell their mother over and over and over again that her husband is dead.
Mm-hmm.
So, yeah, I don't recommend it.
I'll just make one other personal observation. It's getting close to 1, and this has been fantastic. And we did have lots of great questions. Thank you for answering them. One thing I was instructed to do as my loved one was starting to get more and more forgetful was, don't ask her questions, tell her things. So instead of saying, how many children do you have? Tell her, oh, you have 3 children and their names are so-and-so and so-and-so. Do you agree with that?
I do agree with that. I mean, we tend to quiz people a lot, and, you know, imagine if you can't remember anything and someone's quizzing you all the time. You get very frustrated. And, you know, what we see with behavior in Alzheimer's disease is really that normally comes out of a place of frustration. And if we're cautious and careful and educated about how we interact with people, we can really avoid a lot of what we call the common behaviors in Alzheimer's disease. So definitely quizzing people is one of those things. Don't you remember me? Don't you remember? Don't you remember? Well, no, if I could remember, I would remember. Thank you very much. So I always say either putting an answer in a question. For instance, if you say, what do you want for lunch? That, for a person with Alzheimer's, that's a very hard question to answer, right? Because they have to think and think and think about it. But if you say, do you want chicken noodle soup or tomato soup for lunch? Then they have a choice that they can make, right? So it's simplifying. So you've provided the answer in the question, and that's the kind of question you should ask. The other thing is, instead of asking a question, I always use the phrase, tell me about a time, or tell me about your prom, or tell me about, whatever the thing is that you want the person to tell you about, because that allows them to share what they remember and not what we want them to remember. And most of all, we have to learn when we have loved ones with this illness, and it's very hard and very painful, that this is not about us. This is really about their inability to do something. So if they're cross with you, if they're angry, if they're forgotten your name, it's not because they don't, it has nothing to do with anything except their illness. And it certainly doesn't have anything, though it's very painful, it really doesn't have anything to do with you. And you have to sort of build that distance a little bit so that you can be a more positive and successful caregiver. And just to piggyback on that, we do have a class called the Savvy Caregiver, which is a 6-week class for family caregivers only, not professional caregivers, only family caregivers, where we teach you all kinds of things about taking care of somebody at home with this illness, but also taking care of yourself. And if I can leave you with something, it's that if you are a family caregiver, you really need to make sure that you're taking very good care of yourself, because what we see is that caregivers get very sick and their loved ones keep right on going. So you definitely want to take care of yourself, because it really takes, this is one of those, it takes a village, it really does. So get the support that you need.
Thank you. And people can find information about that Savvy Caregiver on your website?
They can find it on the website. They can find it, they can call our 800 number and say where they live and they'd like to be informed if there's a class going on near them, and I will eventually get that email from our helpline that this person is interested. I'm planning to do one here in Tyson's over the summer sometime. It hasn't been completely fixed yet, but definitely I think it's a great class. And if you have 2 hours a week for 6 weeks to do something good for yourself as a caregiver, I think this class is a great thing.
That sounds fantastic. And you did give us all of the contact information on a slide, which participants, you should have received slides from me this morning, so you have all that information. And Diane, I want to thank you so much again for sharing all of this great information with us. As we end the webinar and as you sign out, you should get a brief survey. If you could help us out by responding to our survey, just a few brief thoughts on the webinars and the process, we would appreciate that very much. It helps us keep our programming relevant for you. Thanks again, Diane, and thank you everybody for being here.
Take care, everyone.
Bye.
Bye-bye.